Good afternoon. Thank you for this wonderful opportunity to be with you and share my ideas about dietary therapy in CDG with you again. We heard a lot of great talks this afternoon, and I'm thinking about somehow reviewing what we learned this afternoon. And then you'll be all ready for the test, the exam we are taking at the end of the day. Like when you learn a lot, then you have to show. So, of course, we go through glycosylation. I just realized while sitting here that we saw about 30 different graphs about glycosylation. Some of them went to the right, the other ones to the left, not just to confuse you, but confuse us as well. So glycosylation is a stepwise metabolic process. And as you see, these little lipid arms are there to catch your sugar and make your wonderful sugar tree. And each step is an enzyme. And so that's how these CDGs can be so different, because each step can go wrong. So here's your protein. And your protein needs antennas to function. So those little antennas have to be placed on your protein to be correctly folded and to have normal functionality. So are these antennas always the same? Actually, this is our major antenna. You probably saw many of these colors. So remember, the blues are glycanox, then the greens are the monos. That was really the most important. We learned that without monos, we cannot make the antennas. But there you see also the galactose at the end, and at the very end, the sialic acid, which makes it negatively charged. So you can actually assay for abnormalities and have a good read off whether you have normal or abnormal glycosylation. There are also other antennas, but they are less abundant. And so what happens in the different synthesis steps, you're missing some of the sugars, and according to that, you have a different defect. So dietary therapy is always my favorite. Actually, that's the easiest. It's much better than taking drugs. You feel much better about being a doctor if you can just alter diet and see effects. So first you have to have a real good diagnosis before you try anything. If you prove that you have a diagnosis, you have to have a hypothesis about how this disorder leads to a certain defect. So you really have to understand the biochemical details in order to design a new therapy. So the next thing is what we heard just 2 talks ago, that we can figure a wonderful supplementary therapy. If that certain sugar wouldn't go to the place where it's supposed to be, then that's not feasible. Then we have to modify, and it will be a drug instead of a diet. And then, last but not least, is it safe? I think we all sit with this question, like, can we experiment on our children with changing the diet, giving medications? How would we know if it's safe today? It will be also safe in 10 years when we are keeping on giving this certain medication. So we need the read-offs. And this slide is stolen from the Nijmegen's group from Dirk Lefever. I think it's really a cool idea to think about this as a barcode for a disease, because actually those little glycans are in a specific pattern. So when you do a blood test, and what we learned that transferrin analysis is one of the best tests, then actually you see these little letter patterns, and you can think of a certain disease just evaluating that pattern. So that's our barcode. Of course, there are other possibilities, because you want to test your glycosylation defect in cells as well, not just in blood. So a very easy way, we also saw examples today, to use fibroblasts. So take a skin biopsy, grow the cells, then you get these beautiful structures. There on your right, you see this structure labeled. So we used immunofluorescence to show the nucleus, which is blue, and then show the cell itself, which is green. And if there is a healthy cell, then you will see in culture many of these cells next to each other, and they would be beautifully colored by this immune fluorescent dye. And you can actually look into the microscope and see whether the cells are healthy. So these are our readoffs. And now comes biochemistry. So this will be the 5th question in your test, what we will fill out at the end of the day. So listen carefully. There's no test, Vanessa, I think, unless, where is Vanessa? Yeah, did you make some tests for the parents, like they have to pass? So if not so, then just bear with me for a moment. So all these sugars are swimming around in our blood, but they have to get into the cells. So you see glucose or mannose, we pick it up from the bloodstream, and then we have to activate them. So that's really, really the most exciting part when you're thinking, yeah, I need these phosphorylated, UDP-lated sugars in order to be able to make my antennas. So remember, we were talking about Fiona's disease. There was the stop just right before the activation of mannose. And then we were thinking about it, how would be it possibly treatable? So how can I measure if my treatment method is working? One is just assessing blood, we know that. And another option is to assess her cells, whether they get better on mannose treatment. She had, unfortunately, anemic episodes as a side effect of mannose, but many of our patients with 1B are reacting really well on mannose therapy. So if you think about the cells as not having enough glycosylation, so remember that surface picture, your barcode, if it's absent, you get no staining. So you see only the nuclei because the cell surface doesn't show the glycans, they won't get the staining. Compared to a healthy control, which will show a full surface staining. So if you do mannose feeding in a patient cell, before the mannose staining, you see darkness. There is no immunofluorescence showing the glycans, the barcode for the disease. Amazingly, if you feed these cells with mannose, you see an almost total restoration. Remember, we talked about this, that this is one of the best dietary therapies because you see a very quick effect. What do you think? Would this mean that all patients will react the same way to mannose therapy? This is only in vitro, so we measured it in a flask under the microscope, not in the patient. When you look into the literature or you just talk to your patients about mannose success, some patients develop side effects, other patients don't need so much therapy, and several patients are on really high dose, even higher than 2 grams per kilo per day. So I think all therapies should be tailored to each individual patient. So how would you understand how this works? So actually just step back for a minute and think about it. If you have a block here, then you have to go that way to activate your sugars, your mannose, remember that was the green one, and get it into that beautiful glycan. We already studied how it builds up. So this seems like really an easy way to understand that when there is a block, if you take the mannose, it will go into the system as a bypass. So you don't have to overcome a block. You just stream in between the defect and the further metabolic pathway. So it seems like this is really logical. It's easy to understand and easy to deliver. But if you think about CDG1A, you see the block. If the block is there and you get your monos in there, you have to overcome the block. So the difficulty is you're working against the block, and you might get some storage of the molecules you're feeding your patient. So how is it possible that it still works in some of the patients? You either have an enzyme deficiency, which is not so severe, and maybe that enzyme has enough residual activity that you can overcome the block and get some monos into your system. Or maybe you have another enzyme which is helping you to do the job of the faulty enzyme. And maybe there is another enzyme which can activate your monos and get in there. We call them moonlighting enzymes. There is a lot of research on how we can use other enzymes to take over for the function what we are missing. But the third theory would be that maybe there is something else going on. It's not just the sugar, but maybe the enzyme production or the genetic activity will alter in that patient when we are stimulating with a certain sugar. And maybe we can make more proteins, more active proteins in that patient. And that would be the reason we can overcome a defect like that. So just to review Fiona's story, she was really very special because she was suffering a lot of the side effects of Mondo's therapy. And unfortunately, Mondo's didn't work so well in her in long term. She received her liver transplant, and since then, she's a healthy woman. So Mondo's therapy in CDG1B is really effective, but it doesn't treat the disease. So how about other CDGs? Do we have a better example, or do we have a better success for dietary treatment? So Professor Marquardt also talked about this disease. This is a recently discovered disease very close to PGM3 deficiency we just heard an excellent talk about. However, these patients have really lucky moment because their central nervous system is not involved in this disease. They do have muscle symptoms. They do have recurrent hypoglycemia. They have a very significant risk for bleeding. They have hormonal disturbance. Many of them have a cardiomyopathy, but they do have a normal intelligence. And if you just look at those symptoms, these are really very common CDG symptoms. However, normal intelligence is only in a few patients in the group of CDGs. So how can we diagnose this disease? It's the same way, screening it in blood or measure the enzyme, or you can measure actually the protein amount of the enzyme. So that protein amount we measure by Western blot. So it's not the enzyme activity, it's the amount of protein which is there trying to make its work as an enzyme. So what do you see in these patients? You have the barcode again. If you compare for your right with for your left barcode, then you see that for your left, that's a normal pattern, and you see a significantly abnormal pattern in these patients. And then if you really look into the structure of glycans, remember the green was monos, the yellow was galactose, and at the end there was the sialic acid. We see that most of our patients are missing the end. The glycans are truncated, so you don't get the negative charge at the end, and you also miss galactose. So that's sort of interesting, because What kind of defect is it? Oh my goodness, here is an even more complicated graph. So this is the first graph, just I made it even mind-blowingly complicated. So if you look at your bloodstream, remember the first slide showed mannose and glucose swimming around. So of course, galactose, one of the most important sugars in your life, because that's how you start your life. You start with breast milk, and that's full of lactose, which is half galactose, half glucose. So you have that galactose there, and it's really important that actually your activated galactose is completely imbalanced with your activated sugar pool. So what happens in this disease, we don't really understand, but we do see that the patients have really very low galactose built in the sugar chain. So just pure, what should I do with this patient? You would think, okay, there's not enough galactose, let's try to give some more. This was supported by some experiments we did in vitro. So we did measure the effect of galactose in skin cells. So if you want to see how it looks, actually, this is one of our beautiful patients with a PGM1 CDG. So here you see the glucose. The glucose is the red dot. The enzyme deficiency is here. You see you have a block in your activated sugar metabolism. And remember, the activated galactose is communicating with the pathway of the activated sugar. And then both are important to get into your sugar antenna. So now if somebody is like looking at my graph and it's like, where are the red dots? You see any red dots? So no, we actually don't have the glucose in the final antenna structure. It's a signaling sugar which is very important in actually the first part of glycosylation, and later on these glucose molecules would be removed and only the galactose gets into your final antenna. So let's give this patient galactose the same way we were giving mannose to the other patient and see what happens. So a most simplified way of showing this would be just to go through activated galactose and see whether it would get into the antenna structure. So what you see are cells from our patient with the PGM1 deficiency. Remember, darkness means that there is no good surface glycosylation. You give the galactose and you see a significant improvement. I hope you can see it. It's not so overwhelming as what we saw in mannose. So remember, by the mannose, it was almost normal. And here you see improvement, but it's not total restitution, but it's a significant improvement for sure. So I don't want to bore you because you're probably really tired after all these 2 days. But what's really exciting about treatment with galactose in these patients, that when you have abnormal coagulation results, these results restore in 6 to 12 weeks. So if you see the different coagulation and anticoagulation factors throughout 12 weeks of feeding galactose to our patients, this totally restitutes the levels. They have no more bleeding episodes, no bruising, no nose bleeding. It totally gets better. There are also improvements in liver function tests, less frequent hypoglycemia. The hormonal disturbance normalizes a little bit longer. It takes longer than the coagulation factors. Actually, the most improvement we see after 6 months or a year when we keep on giving galactose. However, the heart doesn't improve. That's really sad. But maybe the heart defect is a genetic defect and would be hard to change that by dietary changes. So make the long story short, galactose seems to work really efficiently in this disease for certain metabolic parameters and for certain laboratory parameters. It's very quick and 100%. For certain other parameters, for example, liver function tests, it's almost perfect, but not 100%. And there are certain organ abnormalities which wouldn't get any better. So this is still not optimal therapy, but a very promising therapy. So let me show you something which is really exciting, and these are my last two slides. When we were thinking about how galactose can improve glycosylation in our patients, we were thinking about how come the block is in sugar metabolism. Remember the red dots? They are glucose, activated glucose. And we are treating this disease with galactose. I wonder if this is just an effect on sugar fluxes and maybe activated sugar molecules, or maybe there's more into this. So interestingly, we have a patient with Thomas Honzik who we put on experimental therapy, and Thomas collected blood samples from this patient. We isolated leukocytes. So actually, we didn't measure this anymore in cell culture, but we actually monitored the patient during therapy. And what we measured, that the actual protein amount, the enzyme protein amount, it shooted up, and it went even beyond normal amount during therapy. So it's obvious that galactose has an effect on protein expression, not just glycosylation, but affecting this enzyme molecule and the production of this enzyme protein. The question is whether this faulty protein would be able to take over the function, because the enzyme is still deficient. We just have more protein of that deficient enzyme. What we see that in some patients we see really an amazing increase in enzyme volume. In other patients it doesn't work at all. We cannot even get it 10% higher. But that's something which really made us think about galactose differently. And this thinking process is according to these lines. There are different genes related to CDG which show increased expression when we give galactose. So when you just take different CDG genes and you give galactose to the cells of these patients, you see that the gene, which is coding for the disorder, would express more protein and would make more transcripts. So somehow galactose seems to activate these genes even in healthy people, not just in CDG patients. So that would make us think that maybe galactose has a more relevance than just on PGM1 deficiency, because if it affects our gene expression, how much protein we make through different CDG genes, then galactose can be maybe beneficially for other types of CDGs. The great thing about it, that galactose is just a normal food supplement, so it's not a drug. You don't have to be scared that you give galactose to your child that would have a side effect. What is really coming up now is a study when we try different disorders and see whether galactose has the same beneficiary effect on all of these different CDG genes. I can tell you already now that there are certain genes which are not reacting to galactose at all. For example, the sialic acid transporter gene doesn't change in any way in expression. One more thing maybe about long-term therapy. I think we still have to learn about sugar pools in our body and alternate pathways. Just want to share with you an experience through CHOP. CHOP has a very severe PGM1 deficient patient who was diagnosed and put on lactose therapy. So lactose is galactose and glucose. So it was not galactose, but lactose. That patient didn't react and was really sick for years, had a G-tube, had a trach, had severe hypoglycemias on multiple drugs. The parents just keep on insisting taking the lactose after a year, and then what we see after the second year, the labs start to normalize, and coagulation, liver function tests, even the transferrin pattern improved significantly. So that's just something to think about. Maybe we are always thinking about quick effects and giving a diet or giving medication and have an effect in our children. I think we still have to learn about long-term effects and be maybe patient with certain therapies and see how it will end. So it's a big team who's actually making all this research possible with collaboration between different hospitals and laboratories. I really appreciate your patience and interest, and thank you.